Hi guys, it's that time again. Welcome back. Here we will cover chapters 21, 27, and 29 that will review fluid and electrolytes, the immunologic alterations, as well as your cellular. First, we will look at chapter 21, fluid and electrolyte alterations. Please do review and refresh yourselves with the anatomy and physiology in your text on page 656 and 657. We will start by looking at electrolyte imbalances. Serum electrolyte concentrations within the ICF and ECF vary slightly between adults and children. Although many electrolytes are found in the body, all serving vital functions, sodium and potassium are the major electrolytes that influence fluid balance. Normal serum levels of these electrolytes are listed in your text in Table 21-3. Electrolytes influence the formation and retention of water in the ICF and ECF and can have a dramatic effect on the function of vital organs. If you are looking at your table in your text, Table 21-3 on page 658 does review the normal serum concentration for sodium, potassium, and chloride. I do want you to notice that for all of them, they give you the differences or ranges for newborns, infants, children, and adults. You need to know the differences between your newborns, your infants, and your children. That is for both sodium and potassium. When looking at a sodium imbalance, sodium is the major extracellular electrolyte, and it is responsible for establishing and maintaining osmolarity. Hyponatremia is a decreased serum sodium concentration less than 135. When serum sodium level decreases, water shifts from the F to the ICF to equalize the osmolality. Hyponatremia can be caused by excessive administration of sodium bicarbonate or baking soda, diarrhea, vomiting, nasogastric suctioning, diuretics, water intoxication, malnutrition, excessive sweating, burns, diabetic ketoacidosis, renal disease, and cystic fibrosis. Children with cystic fibrosis lose excess salt when they sweat, making them susceptible to hyponatremic dehydration and metabolic alkalosis. Signs and symptoms of hyponatremia are irritability, disorientation, lethargy, seizures, headache, muscle cramps, abdominal cramps, oliguria, and cerebral edema. Care for hyponatremia includes treating the underlying cause, carefully replacing fluid with a hypertonic saline IV, frequently assessing the patient's neurological status, and, of course, monitoring the serum sodium level. When we look at hypernatremia, this is an increased serum sodium concentration greater than 145. Now, if you refer back to your table, you may see that the higher limit for the child is 148. So you would have to judge accordingly based on whether it was an infant or a child. Of course, if it is a child, then we would consider our hypernatremia greater than 148. So do make note of that. Make a mental note on the levels. It's very important to know those levels for the sodium and potassium and the differences. When we have hypernatremia, fluid moves from the ICF to ECF, causing cells to shrink. It is caused by an excessive intake of sodium or an increased water loss. Conditions related to hypernatremia include diabetes mellitus, diabetes insipidus, diarrhea, increased insatiable water loss, and dehydration. Symptoms in infants and children can include extreme thirst, agitation, a high-pitched cry, flushed skin, lethargy, muscle weakness and twitching, seizures, and even a coma. Under normal circumstances, an elevation in serum sodium causes antidiuretic hormone to be released and stimulates thirst. Critically ill children may not be able to respond effectively to these compensatory mechanisms. Care for hypernatremia includes, of course, treating the underlying cause, strictly monitoring intake and output, frequently assessing the patient's neurological status, and slowly correcting the fluid deficit, as well as monitoring those serum sodium levels. When we look at the potassium imbalance, you want to note that potassium is a major electrolyte in the ICF with a concentration of 160 inside the cells. However, potassium is readily measured in serum and ECF where the normal concentration is 3.5 to 5. If you notice, the level is different for a newborn versus an infant, so take note of that as well. From infants onward to adults, the measure is 3.5 to 5. If you're dealing with a newborn, that first day to the first 28 days, we're looking at potassium levels from 3 to 6. So notice the difference. It has vital roles in the body, including maintenance of osmolality and acid-base balance, transmission of nerve impulses, electrical conductivity, and contractions of skeletal and cardiac muscles. You want to know that any potassium imbalance can greatly affect the heart muscle contraction. For example, an elevated serum potassium can cause cardiac irritability, which can lead to ventricular fibrillation. Cardiac irritability associated with an elevated or decreased serum potassium can be seen on an ECG. Hypokalemia is a decreased serum potassium concentration of less than 3.5. If we're looking at newborns, it would be less than 3. That results from a true potassium deficit or a potassium shift from the intravascular space to the ICF. Symptoms include lethargy, irritability, nausea, vomiting, abdominal distension, paralytic ileus, arrhythmias, decreased blood pressures, and ECG changes. In particular, a flattened T wave, ST wave, depression, and premature ventricular contractions. Care for hypokalemia includes treating the underlying cause, replacing potassium loss, monitoring those levels, and serum pH, monitoring the ECG, and frequently assessing for neuromuscular changes. When we look at hyperkalemia, this is an increase of serum potassium concentration greater than 5. If we're dealing with newborns, it would be greater than 6. That can result from crushing injuries, burns, tissue necrosis, hemolysis, renal failure, severe dehydration, or a rapid infusion of potassium. Clinical manifestations of hyperkalemia include abdominal cramps, nausea, vomiting, diarrhea, muscle weakness, hyperreflexia, confusion, apnea, arrhythmias, and ECG changes, in particular, tall peak T waves and widened QRS complexes. And this will lead to cardiac arrest if it is not treated quickly. Care for hyperkalemia includes, of course, treating the underlying cause, holding medications and fluids that contain potassium, monitoring those ECG changes, carefully administering insulin and glucose to move the potassium into the cells, IV calcium or K-exolate, and monitoring serum pH and the potassium levels. Before we move on to talk about acid-base balance and imbalance, I do want you guys to take a look at the chart in your text on page 660 and 661, which looks at disturbances in the fluid and electrolyte balances. In particular, you want to look at potassium and sodium and look at the differences, especially when you're looking at potassium, how it actually affects your ECG and other relative changes that you may see that the child exhibits, whether it is high or low. Now we will look at acid-base balance and imbalance. Homeostasis in body fluids is also affected by acid-base metabolism. If you may remember, the normal pH ranges from 7.35 to 7.45. A blood pH lower than 6.0 or higher than 7.80 is incompatible with life. Acidosis is indicated by a blood pH below 7.35, while alkalosis is indicated by a blood pH of 7.45. This will take you back into your chemistry days when you had to do or figure out whether it was respiratory alkalosis, respiratory acidosis, and things like that. I do have a nifty chart that I will give you guys in class that can better assist you with understanding and figuring these out. We won't go into detail too much in regards to the imbalances, as this should be merely a review for you guys. The respiratory system controls acid-base metabolism by retaining or releasing carbon dioxide, thereby causing a shift in the bicarbonate carbonic acid buffering system. The amount of dissolved carbon dioxide in the blood, known as the PCO2, is measured by an ABG, or your arterial blood gas, and ranges from 35 to 45 millimeters of mercury. Your carbonic acid, which is your H2CO3, is a weak, unstable acid formed when carbon dioxide combines with water, which is your H2O, of course, that will dissociate into bicarbonate and one hydrogen ion, your HCO3. Bicarbonate levels are measured by an ABG and range from 22 to 26. To maintain a stable acid-base balance, the body will try to maintain a 20-to-1 ratio between bicarbonate and carbonic acid, and an equilibrium of carbonic acid and dissolved carbon dioxide found in the blood. The lungs will compensate for pH changes caused by metabolic disorders such as diabetes, vomiting, and diarrhea by controlling the carbon dioxide level in the blood. Hyperventilation or deep rapid breathing, known as cosmal respirations, will occur in an attempt to blow off carbon dioxide. The kidneys will compensate for pH changes caused by respiratory problems or buildup of metabolic acids, such as your lactic acid, hydrochloric acid, pyruvic acid, and sulfuric acid, by controlling hydrogen ion and bicarbonate levels in the blood. However, renal compensation is much slower than respiratory compensation and often requires days to restore balance. Compensation is a body process to restore blood pH to normal by changing the partial pressure of carbon dioxide, or your PCO2, or the bicarbonate ion concentration. Acid-base imbalances are common in children and fall into 4 categories: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. We will first look at respiratory acidosis. This can be caused by any condition that decreases a child's respiratory effort. Slowed or shallow respirations will result in a buildup of carbon dioxide, which combined with water forms carbonic acid and leads to acidosis, a decreased pH, and an increased PCO2. Acidosis causes central nervous system depression. As a result, the child will be lethargic, confused, and disoriented, and may complain of a headache, and if not treated, may become comatose. Efforts to improve ventilation help correct the underlying cause of respiratory acidosis. Without correction, the body, via the kidneys, will retain bicarbonate to help neutralize the increased acid. However, the kidneys' attempt to compensate is slow and does not correct the underlying respiratory problem. When we look at respiratory alkalosis, this occurs when carbon dioxide levels are too low. This mostly commonly occurs from conditions that cause the child to hyperventilate, such as anxiety, pain, meningitis, gram-negative, septicemia, early response to salicylic poisoning, and mechanical overventilation. The child will often feel numbness or tingling in the toes and fingers, lightheadedness and confusion, and may even faint. Renal compensation for respiratory alkalosis is rarely seen clinically because the underlying condition is often corrected before the kidneys have time to respond. When we look at metabolic acidosis, it is commonly caused by a loss of bicarbonate in the stool or an increase in ketone bodies in the blood. These conditions most frequently result from diarrhea and diabetic ketoacidosis. Children are often confused, lethargic, and tachycardic. The body compensates by increasing the depth and rate of respirations in order to blow off carbon dioxide, thus decreasing the PCO2 and carbonic acid. On the other hand, we look at metabolic alkalosis. This occurs as a result of bicarbonate retention or hydrogen ion loss. It is most commonly seen in children with prolonged vomiting or emesis, as emesis is acidic to the stomach contents. It can also occur with ingestion of large quantities of bicarbonate antacids, massive blood transfusions, loss of nasogastric fluids due to gastric suctioning, and hypokalemia. A child experiencing metabolic alkalosis is often weak and dizzy and may complain of muscle cramping. A good little review is in your text on page 663 in table 21-5. There's a comparative analysis of the acid-base disturbances. That will be good for you guys to look at and review. Now we will look at dehydration and hypovolemia. Terms dehydration and hypovolemia are often thought to be the same, but they are not. Hypovolemia is a decrease in the circulating blood volume, and dehydration is a deficit of total body water. Severe dehydration can lead to hypovolemia, hypovolemic shock, end organ failure, and even death. Clinical manifestations of hypovolemia and dehydration have some overlap. The most definitive sign of dehydration is weight loss. Clinical dehydration is classified as mild, moderate, or severe. Mild is less than 3% weight loss, moderate is 3 to 9%, and severe is greater than 9%. However, this is often difficult to determine because many parents do not know their child's baseline weights accurately enough to determine how much weight may have been lost before they sought health care. 3 signs found to be most indicative of dehydration are poor skin turgor, prolonged capillary refill, and an abnormal respiratory pattern. Other indications of dehydration include a recent history of diarrhea and or vomiting, parental report of the child experiencing decreased urine output and or poor fluid intake, decreased or absent tears, dry mucous membranes, tachycardia, sunken eyes, sunken fontanelles in infants, cool extremities, and a generally ill appearance. Children vary considerably in how they exhibit dehydration. When assessing the severity of a child's dehydration, it is helpful to consider many signs of dehydration they have rather than relying on one single indicator. Table 21-6 in your text on page 665 gives you a summary of the clinical manifestations according to the degree of dehydration. So if it is minimal, it tells you some things that you may see versus whether it is severe and what you may see or the child may exhibit during that time. I want you guys to look at and review the types of dehydration, and then we will move on to the incidence and etiology of dehydration. Although the exact incidence of dehydration is unknown, it can be caused from many common illnesses or prolonged NPO status in preparation for many hospital procedures. Infants and children under 5 years of age are at most risk for developing dehydration. Morbidity and mortality are associated with the severity of dehydration and the rapidness of treatment initiated. When oral or intravenous rehydration is initiated quickly and appropriately, recovery is usually complete. Nevertheless, diarrhea associated with dehydration remains a significant cause of childhood mortality worldwide. I do want you guys to look at the nursing tip in your text on page 666, which goes over assessing fluid, electrolyte, and acid-base alterations, as well as the nursing tip on page 667, which tells you diarrhea is not a disease. We will look closely at the underlying causes of dehydration and hypovolemia. Determining the cause of dehydration and or hypovolemia is often essential to effectively treat. Gastroenteritis is the most common cause of dehydration, and in this case, dehydration is primarily caused by fluid loss. If the child is vomiting and experiencing diarrhea, the severity of the dehydration can quickly intensify. Other illnesses can lead to dehydration by decreasing a child's willingness to drink and eat. Likewise, any febrile illness increases insatiable water loss and can cause irritability and a diminished appetite. Some causes of dehydration require rather complex treatment. When we look at caring for children with dehydration, treatment of dehydration depends on the severity of the actual dehydration. Table 21-7 in your text provides recommended rehydration based on the degree of dehydration. The focus is on correcting the fluid and electrolyte imbalances and treating the underlying causes. If nausea and vomiting are the cause of diarrhea, oral ondansetron may reduce vomiting, which is your Zofran, and improve the chances of success with oral rehydration. Dehydrated breastfed infants should breastfeed more frequently and for less time than their normal routine. For other dehydrated infants and children, rehydration solutions should be initiated without a period of gut rest and given frequently, such as every 5 to 10 minutes in small amounts, such as 5 to 10 mLs. Volume can be increased and given less frequently as the vomiting subsides. The United Nations Children Fund and World Health Organization recommend oral rehydration solutions, or ORS, as the first-line therapy for mild to moderate dehydration. Appropriate oral rehydration solutions such as Pedialyte, Litrin, Infolite, and Resol are available commercially. I'm sure most of you know of the Pedialyte. That is the one most people use. When children with moderate to severe dehydration refuse to drink or are not tolerating oral fluids, other methods of rehydration are needed. In such cases, rehydrating through nasogastric tubes is often successful. However, when dehydration is severe or vomiting is uncontrollable, IV therapy should be initiated. In the event that venous access is not obtainable, an IO administration of fluids is a viable option. Note that the type of IV solution used varies with the type of dehydration, but generally isotonic dehydration is the most common type in children, and it is treated with isotonic fluids, which are your fluids that have the same concentration as normal body fluid. I do want you to look at the nursing alerts as well as the family teaching in your text on page 668, which goes over fluid loss due to hemorrhage, dehydration from diarrhea, and the family teaching, which goes over dehydration. When we look at nursing management for dehydration, when assessing hydration status, the nurse should assess the color, warmth, and turgor of the child's skin. The skin may feel cool, and the child may complain of cold fingers and toes with decreased perfusion. Capillary refill time will also be prolonged, 3 to 4 seconds or more, as perfusion decreases. Extracellular fluid losses will cause the skin to become dry and loose, referred to as a loss of skin turgor. Tears should be present if the child is crying. In children less than 18 months of age, it is also important to check the anterior fontanelle. Nurses should also assess the mucous membranes for presence of dry and sticky mucus, and then, of course, assess that absence or presence of tears. Dehydration is getting very bad if we have no tears at all. When the child is dehydrated and they are less than 18, that fontanelle is often depressed or has a sunken appearance. Weight is a critical indicator of the child's fluid status and should be compared with the pre-illness weight, if that is actually available, or the weight from the previous day. The nurse should also assess for intake and output. The child's urine should be observed for amount. Diapers weighed if the child is still in diapers. Finally, excessive perspiration may require estimating fluid loss by weighing the clothes and linens. The use of radiant warmers or warming lights can also increase insatiable losses in small infants and should be monitored. So that means don't stick them under a heat lamp if they're in the hospital. Several behavioral changes may also be present in children with dehydration. These include decreased activity levels, loss of interest in their environment, restlessness, irritability, lethargy, and a high-pitched, weak cry. The last assessment should include a review of serum electrolyte results. You want to also look at the nursing alert in your text on page 670, which goes into adding potassium into the IV solution. You want to first make sure that the child is able to void at least 1 to 2 mLs per kilo per hour, adding potassium before adding that potassium to the IV. Never give, of course, more than 40 at a rate not to exceed 1 milliequivalent per kilo per hour. So that's where you're going to go into pediatric calculations if you do have to add that. When we look at family teaching, nurses recommend rehydration fluids and discuss how to administer them. Dehydration can often be managed at home if caregivers are well informed and prepared. They need to know the signs of dehydration and should watch for lethargy or changes in their child's normal behavior. They should also be alert to changes in their child's urine output. You want to help them to be able to make accurate decisions as to when to contact the health provider. No improvement after 4 hours of rehydration fluids, inability to retain fluids, decreasing urine output, and change in mental alertness would all be key essential education factors for parents to know. Now, I want to look at a few examples before we move on to acute gastroenteritis. If you're a child with a cold or a fever, as the nurse, you want to ensure that their fluid intake is adequate so that the parents can prevent dehydration. This is a key element to preventing dehydration because, of course, we all know when children are sick, they do not want to eat or drink very much, so we do want to make sure they are getting the necessary replacement fluids even if they are under the weather. Also, like your text said, note for the fontanelles, if you are checking a child that is less than 18 months, if they are indented or sunken, that may indicate dehydration for your newborn. Also, if an infant is hospitalized for dehydration. Let's say it's related to rotavirus. The priority nursing, I would say the priority nursing intervention would be maintaining the IV fluids. Because if you have an infant, if they're breastfeeding, they may not breastfeed as well. You don't want to pass the virus along. They may not be doing bottle as well. So that'll be when we want to introduce those IV fluids. So you want to make sure you're maintaining those fluids as ordered per the physician or other healthcare provider. If you are administering IV medications for a child with dehydration and you notice an increased pulse and blood pressure and also extremely diluted urine, you want to suspect the child is in fluid overload. This is key. We are assessing these kids quite frequently, and this is due to the fact that everything is based on weight, and if it is being administered too fast or given in excess amounts, the child can go into fluid overload. So you do want to look at signs, which would be that increased pulse, that blood pressure, and the diluted urine. Now, if you are teaching a parent, let's say, about an enema, not only about dehydration, because giving an enema can cause not only the child to have a bowel movement, but it may lead to diarrhea. You also want to teach them about the amount of solution that is in the bottle. For a child, it should be no more than 500 to 1,000 mLs in the enema bottle. That is priority, that you do want to teach the parent not only about the solution, the amount, but how to monitor for signs and symptoms of dehydration if they actually do need an enema. And this would be more for if your child had some kind of constipation. Okay, let's quickly and briefly look at acute gastroenteritis. This is a disease that causes inflammation of the mucous membranes of the stomach and the intestines. Symptoms may somewhat vary depending on the causative agent, but generally include nausea, vomiting, diarrhea, fever, abdominal pain, headache, and electrolyte imbalances. Most cases of gastroenteritis are self-limited. However, more severe or prolonged illnesses can result in dehydration with significant morbidity and mortality. Children who attend daycare centers, schools, institutions, and other facilities are especially susceptible to episodes of gastritis. It is caused by a variety of viruses, bacteria, and parasites. If you want to look in your text at page 671, there's a table 21-8 that lists some of the pathogens that cause acute gastroenteritis. Briefly review your pathophysiology for this disease, and we will look at diagnosis, which is based on the history, physical exam, and laboratory studies focused on evaluating the child's hydration status and identifying the causative agent. The history should include the following data, such as recent exposure to infectious agents, travel history, especially if outside of the U.S., exposure to contaminated food and water supplies, exposure to turtles, iguanas, other reptiles, roaches, flies, and mice. Attendance at a daycare center should also be considered. The child's hydration status is evaluated, including history of fluid intake such as types, amounts, and tolerance, as well as urination frequency, amount, and color are also investigated. Generally, if no symptomatic manifestations are present, and if dehydration is absent, diagnostic laboratory testing are not indicated. If dehydration is present, additional tests may be performed to evaluate hydration status, such as a CBC urinalysis, a BUN, and electrolyte studies. When caring for children with gastroenteritis, treatment for this focuses on fluid replacement and correction of electrolyte disturbances, and is dependent on the degree of dehydration. In addition to addressing issues associated with dehydration, further steps are needed when children have gastroenteritis. It is important to teach care providers how to minimize the spread of gastroenteritis with an emphasis on the need for good hand washing. Caregivers should be instructed to change diapers frequently to prevent irritation to the skin, wash perineal area with mild soap and water after each diarrhea episode, and apply protective ointments to the buttocks. Most cases of bacterial or viral gastroenteritis are self-limited and do not require any medical therapy. I want you guys to look at the nursing alert in your text on page 672, which goes over the BRAT diet for gastroenteritis. Briefly look at edema. I do want you to read and review this, as it should be quite a review. Edema is an excess accumulation of interstitial fluid that usually results from a disturbance in the fluid exchange between capillaries and the interstitial space. We won't go too much over etiology or pathophysiology. I do want you to look at the clinical manifestations, which results in swelling, either localized or general. In most cases, edema in children is manifested initially, periorbitally, or dependently. If the child is ambulatory, dependent edema will be evident in the ankles. Children on bed rest will have edema in the sacral area. Pitting edema is always a clear sign of an extracellular fluid excess. It is assessed by pushing a finger gently into the edematous tissue and observing for an indentation on the skin. The degree of edema is rated on a 5-point scale. You have +0 all the way to +4. Edematous areas may also appear shiny and full. Additional signs may include a sudden weight gain, an elevation in blood pressure, a bounding pulse, neck vein distension, and dyspnea. What do those signs and symptoms remind you of? Should be a cardiac problem. So, you do want to investigate edema very closely, even if it is in the child, and if you haven't already heard it, respiratory problems are usually the primary cause of an infant to be unconscious or have any kind of problems. It is not usually cardiac, which is what we find more often in our adult population. When we look at diagnosis, this is determined based on the clinical manifestations that are identified during the history and physical examination. Treatment: diuretics are given to promote fluid excretion through the kidneys. Since most diuretics cause potassium loss, it is extremely important to monitor serum potassium levels and provide potassium supplements as necessary. When we look at nursing management, this begins through history and physical assessment. Note the location and extent of the edema. The nurse must maintain accurate measurements of intake and output as well as body weight, which should be measured on the same scale at the same time each day. When diuretics are used, blood electrolytes should be monitored for potassium depletion. When we are looking at family teaching, prevention of skin breakdown is paramount. Teach caregivers the importance of good skin care for their child. Edematous tissue is very fragile, and if not kept dry and free of friction, it can easily break down. Special care must be taken to keep the diaper area clean and dry. An infant or child on bed rest should be turned every 2 hours to prevent pressure sores. If the child is on potassium-depleting diuretics, encourage caregivers to include potassium-rich foods and fluids in the diet, such as bananas, apricots, cantaloupe, dates, tomato juice, orange juice, peaches, potatoes, raisins, and figs. Older children may need to be reassured that the edema is only temporary. I do want you to look at your nursing alert on page 677. It talks about burns in the kitchen, and we will talk more about burns in the next slide. Significant research-based advances in fluid therapy, wound care management, and respiratory, metabolic, and nutritional support have improved the survival rate of children with burns. Appropriate care of burns is essential, beginning with early stabilization. The goals of early stabilization are to cool the burn with cool water and prevent further burn on assessment and stabilization of the airway, breathing, circulation, and of course, pain management. The delivery of ideal burn care requires a team of healthcare providers working together, carefully assessing and timing treatments necessary for survival. The team must establish a communication system that includes the child's family so they can be fully informed and current care and prepare for future treatments. Children are at a high risk for burns. It is difficult to determine the morbidity associated with burns because global data on non-fatal burn injuries are not readily reliable. However, it appears that electrical and chemical burns are relatively rare in children, but contact burns and scalds contribute significantly to fire-related disabilities in children. There are four major types of burns: thermal, which is the most common in children, electrical, chemical, and radiation. I want you guys to review the differences between the four with paying attention most definitely to the most common, which is the thermal burn. Again, look at the alert in your text on page 677 with preventing burns in the kitchen, which is usually where they happen most often times. It is difficult to know how many burns in children result from abuse. Although the risk by burns ranges from 4 to 39%, less than one half are substantial. Additional type of burn wounds are common in child suspected. Those are scalding burns from immersion in hot water or liquids, or burns from a cigarette or an iron. Burns to the extremities are particularly suspicious if they are symmetrical. I want you guys to also review your pathophysiology regarding burns, and we will look at the clinical manifestations. The severity of the burn is determined by how deeply the damage extends into the tissue and the total body surface area that's involved. When you look at superficial burns, this is known as your first-degree burn. It involves only the epidermis. A minor sunburn without blistering is an example of a superficial burn. If you do look in your text on page 678, it will go over your superficial thickness burns, partial thickness burns, full thickness burns, and a full thickness burn at a fourth degree. I also want you to look at your table 21-9 in your text on page 679 for body system manifestations after a major burn. This can prove to be very important when you're assessing a child that has been burned. Typically, your first-degree burns, they are somewhat painful for 48 to 72 hours and heal spontaneously without scarring in about 5 to 10 days. Looking at your partial thickness burn, this is known as your second-degree burn, and they are divided into superficial partial thickness involving the epidermis and superficial dermis, and deep partial thickness burns involving the epidermis and the deeper dermis. Your superficial partial thickness burns blister and are very red, moist, and painful. Typically, they heal spontaneously without scarring in about 1 to 3 weeks. Your deep partial thickness burns appear white with less erythema or redness noted as the injury extends deeper into the dermis. Sensation is usually diminished and capillary refill is prolonged. The amount of scarring is associated with how long it takes the burn to heal or the burn wound to heal, which usually is a minimum of about 3 to 4 weeks. When we look at our full thickness burns, this is our third degree burn. It involves the epidermis and the entire dermis layer and can extend into the subcutaneous tissue. They can be white, black, or brown. These burns do not heal spontaneously unless they are small, and then they heal with contraction, which we try to prevent. Skin grafting is usually performed on these types of burns. Most devastating full-thickness burn is your 4th degree burn. These are lethal. They extend into the muscle, fascia, and then the bone. The extent of the burn injury is usually expressed as the percentage of the total body surface area that is affected. If you look in your tag, page 681, you will notice a diagram in figure 28-1, which is estimate of the extent of burns in children. This is an example of what you would fill out if your child were to come in and they were burned. A diagnosis of burns is determined from the clinical manifestations identified during the history and physical examination. When you're caring for children with burns, emphasis is on respiratory management, fluid resuscitation, pain management, wound care, prevention of impaired mobility, nutritional support, and psychological support. When we look at respiratory management, initial treatment consists of assessing airway patency and or establishing it if needed. You also want to maintain it. Pulmonary complications are a leading cause of death in thermal burns. When we look at fluid resuscitation, in early stages following a major burn injury, promptly establish adequate IV or IO access. Usually, IV is your preferred route. If you are unable to get an IV, not often do they do an IO. They may call for a PICC line, central line, or a arterial line. All burns alter capillary permeability. If severe enough, they require fluid replacement. Fluid resuscitation is a major focus of seriously burned children during the initial treatment period in order to prevent hypovolemic shock. Formulas to calculate fluid requirements are generally 2 to 4 milliliters times the child's weight in kilograms times the percentage of body surface area that is burned. That is why it is important to make sure you document correctly on the percentage of the body that is actually burned. And this does take some skill, and even the novice nurse cannot grasp this concept quite well, so it does take a skilled nurse to fill out this assessment as far as calculating the body surface area that is actually burned. After initial fluid resuscitation, capillary permeability is regained. At this time, the child's urine output will increase dramatically because interstitial fluids are pulled back into the bloodstream. When we look at pain management, pain following a burn is acute and chronic. Thermal destruction of tissues result in one of the most severe and prolonged types of pain. Pain from the injury is compounded by performing procedures on the wound, especially dressing changes. Other factors such as fear and anxiety contribute to the child's perception of pain as well. When we look at during wound care, excising and grafting these wounds are associated with high blood loss, and care of the child undergoing excision and grafts requires a highly skilled team of physicians, nurses, and occupational and physical therapists. Hydrotherapy is also a technique that is used to soften dead tissue and help in the debridement process and to improve circulation of the wound. The experience is very painful and scary for all burn clients. Children should be medicated prior to hydrotherapy and dressing changes. It is helpful if caregivers can be present to comfort and distract the child. Once wound grafts heal, pressure dressings are applied to prevent the formation of contractures and minimize scarring. To maximize effectiveness of these dressings, they should be worn almost 24 hours a day for up to 1 year. When we look at prevention of impaired mobility, children are at risk for impaired mobility and development of contractures due to prolonged bed rest, muscular atrophy, and shortening and stiffening of the burned tissues. Early exercise is encouraged and compliance can be improved with judicious use of analgesics. Range of motion exercises are performed actively at least 3 times a day. Active range of motion of the muscles is possible in infants and toddlers by using familiar toys. However, most of the joints will require passive range of motion exercises. In your text on page 684, I do want you to look at the nursing tip as far as calculating maintenance IV rates using the 4-2-1 rule, as well as the fireworks danger alert in your nursing alert on that same page in your text. When we look at psychological support, anxiety for the child and caregivers can be overwhelming. Play therapy is used to help the child deal with frustrations of burn therapy. It encourages the child to actively participate in activities with other children. Nurses in burn units find it essential to gain the trust of the family and the child to create a healing environment in the midst of such a stressful situation. As far as family teaching goes, the home care need of the family should be addressed long before the child is ready for discharge. Discharge teaching often includes nutritional and diet requirements, daily dressing changes, and skincare, application of elasticized garments, and how to change those garments and proper hand washing, as well as application of splints and daily range of motion exercises. Discharge teaching books are often helpful for the families to refer to as they learn. Caregivers may feel guilty because of the injuries that the child has sustained, often coupled with painful procedures without support as well. Home care should emphasize returning the child to as many independent tasks as possible. Alright, let's chapter 27. If you haven't already noticed, we're on slide cycle, very, how shall I say, a very short chapter, but or a condensed chapter. And a lot of this stuff I will tell you to review on your own, and I will just hit on some of the key central within the chapter. So without further ado, here we go, and this is chapter 27, the immunologic alterations. I do want you guys to read and review the brief overview of the immune system and function. This should serve as a review, especially when they're talking about the innate system, the adaptive immune system, your T lymphocytes, your helper cells, your killer T and your memory cells, things like that. All of those should be a review to you. You can look at your table in your thumb page 953, which covers immunoglobulins, and you just want to review those. IgG, IgA, IgM, those should all be a review too. So just briefly look at that chart and read over the action and when they actually appear. One thing that I do want to point out is that you want to make sure that you do review passive immunity and autoimmunity and know the difference between them, as well as your immediate hypersensitivity and delayed hypersensitivity. This can be found in your text on page 954. Now we will look at the rheumatological autoimmune inflammatory diseases. These diseases include juvenile idiopathic arthritis, a new name for juvenile rheumatoid arthritis, and systemic lupus. First, we'll look at juvenile arthritis, and I'll just say that for short, or it's usually called rheumatoid arthritis. If you can remember back when it was called that, they've renamed it, and for saving purposes of saying the whole thing every time, I may just say JIA, so don't be confused as to if I'm referring to JIA and I don't say juvenile idiopathic arthritis every time. There is a nifty little box in your text on page 955 that just briefly reviews some terminology with you as far as autoimmunity and inflammation. You do want to check that out as well. So let's look at juvenile idiopathic arthritis, or JIA. Like I said, it was previously classified as juvenile rheumatoid arthritis, or JRA. It's a heterogeneous group of autoimmune chronic inflammatory diseases affecting the joints and connective tissues in children. JIA represents the most common rheumatic condition of childhood and may present as one of three diseases: systemic onset, poikilocerebral or POCI, involving 5 or fewer joints, or polyarticular, simultaneous involvement of 4 or more joints. You want to review the incidence and etiology. It's the most common disease. I do want you guys to know that. And one of the more common chronic diseases that do affect children ultimately. Although this type of disease or disorder is really life-threatening, the outcome for most children with JIA is impossible to predict. Remember, this does go back to saying how each child is unique. So even if 2 children do have the disease or disorder, their outcome may prove to be different. Approximately 70% of children with JIA may experience permanent remission and function optimally. It is important to diagnose JIA as early as possible to prevent joint damage, growth retardation, long-term disabilities, and poor quality of life. Treatment combines anti-inflammatory and immune modular medications, physical and occupational therapies, your nutritional support, psychosocial and also emotional support, as well as client and family education. Occasionally, surgery may be required. Children at most risk for impairments that come along with JIA have a later age of onset, exhibit prominent systemic manifestations, and develop early symptomatic involvement of small joints such as the hands and feet, or progressive hip disease. 2 peak ages of onset have been identified between 2 and 4 years of age and between 10 and 12 years of age. Overall, girls are affected twice as often as boys. When we look at the clinical manifestations, the most common symptoms of JIA are persistent joint swelling, pain, and stiffness or gelling that is typically worse in the morning. The child may also exhibit limited mobility or range of motion in the limb of the affected joint. Swelling is secondary to joint effusion, edema, and thickening of the synovium. Symptoms and joint inflammation are the main causes of impaired mobility early in the disease process. They also experience a high fever and light skin rash. These may appear and disappear very quickly. There are periods when symptoms are better or disappear, such as the remission, and when they are worse, which are known as our flare-ups. So again, remember that each child is unique in frequencies of remission and their flare-ups. Some children have many flare-ups with symptoms never going away. Others may have 1 or 2 flare-ups and never have symptoms again. When we look at diagnosing this disorder, it is primarily based on the history and assessments. The American College of Rheumatology determined diagnostic criteria for JIA that include onset before 16 years of age, arthritis objectively observed, of at least 6 weeks duration, a defined subtype by onset of characteristics, and exclusion of other conditions such as rheumatic diseases, infectious arthritis, inflammatory bowel disease, and non-rheumatic conditions of the bones and joints. Objectively observed arthritis is defined as joint swelling or effusion or 2 of the following: warmth, pain on motion, or limited range of motion. Diagnosis also considers the child's age, gender, race, ethnicity, history of presenting symptoms, and serology results. The clinical manifestations of the varied forms of juvenile arthritis are also often presenting symptoms of many childhood diseases. Other conditions that have to be ruled out are benign arthralgia of childhood, which are growing pains, rheumatic fever, and school phobia. There are no specific laboratory testing for JIA, even though test results reflecting inflammation are completed and used to help diagnose and monitor rheumatological diseases. They are non-specific and can reflect other conditions causing inflammation. These tests and results include your elevated erythrocyte sedimentation rates, especially for kids, elevated CRPs, your elevated WBCs, decreased hemoglobin and increased platelet counts, your ANA, and your rheumatoid factors are positive in a proportion of children with arthritis. A positive ANA, though, is not itself diagnostic, as there are positive results in about 5% of non-arthritic population, and it is very closely associated with lupus. X-rays can demonstrate characteristic changes such as soft tissue swelling and joint effusion. With continued disease activity, bony erosions and narrowing of the joint spaces are seen. When we look at treatment, it is best undertaken by a multidisciplinary team including the child's family, nurse, physician, occupational and physical therapist, and also a social worker. A variety of medications are the mainstay of treatment for arthritis in children, and the goal is to minimize inflammation, control pain, preserve joint function, and promote normal growth and development. Of course, we want to look at the NSAIDs. Those are usually prescribed. We're looking at ibuprofen, naproxen, indomethacin, and aspirin may be prescribed, but has been linked to Reye's or Ray's syndrome in children exposed to flu viruses and should not be administered if the child develops flu symptoms. So they usually stray away from those. Parents with infants or children with JIA or who are receiving aspirin therapy need to be educated regarding the child's risk of Ray or Rye syndrome, and aspirin should not be administered again if flu symptoms do develop. In your text on page 958, there is a table 27-3 that shows common medications used to control the inflammation, and that is a good little detail box for you to review. As integral members of the team, physical and occupational therapists evaluate the status of affected joints for range of motion, alignment, and strength. Heat and cold application may be recommended to help lessen pain. A therapeutic home exercise program will be useful for maintaining or increasing range of motion and improving strength endurance. Splinting may be needed to protect a joint, decrease pain, or help with alignment. Physical activity options for a child with arthritis are swimming, walking, biking, and should continue unless the joint is acutely inflamed. High impact and contact sports should be avoided. Although activity is important, rest periods may be necessary. The nurse should not forget to consider the child or adolescent school experience, since pain and fatigue may cause school absences and prevent participation in many types of activities. The school nurse also needs to provide support and encouragement when parents and children have questions about what to do when this happens and how to access resources in the community that can facilitate normal social and physical development. When we look at family teaching, education for caregivers and other family members should include information about the disease and medications, diagnostic testing and their significance, physical activity, sleep, and also nutrition. The nurse facilitates family contact with appropriate caregivers. Now we'll look at systemic lupus. This is commonly called SLE, or lupus for short, and it is one of the most common complex serious chronic autoimmune conditions or disorders. It affects multiple systems. Presently, there is no cure, and specific therapies should be targeted to the symptoms, severity of the disease, and the child's response. It can be effectively treated with multidisciplinary approaches that include medication therapies, nutritional therapies, and also physical activities. This can develop at any age. Onset in childhood, though, usually occurs around 12 years of age. Similar to other autoimmune diseases, females are impacted 10 times more than males. The exact etiology of SLE, a chronic complex disease with unpredictable multi-system impact and complications, is of course unknown. When we look at clinical manifestations, individuals with SLE may exhibit a range of symptoms from mild to severe that may come and leave over a period of time. Symptoms include fever, fatigue, weight loss, lymphedema, and hepatosplenomegaly. A predominant manifestation is a malar or butterfly rash on the face resulting from mucocutaneous involvement. Clinical manifestations depend on which organs are targeted by the immune complexes, are chronic, and are characterized by remissions and exacerbations. You do want to refer to your box 27-3 in your text on 962 that goes over the diagnostic criteria for lupus. Diagnosing this can be difficult and is based on history, physical exam, laboratory testing results, and presence of 4 out of the 11 criteria that are listed in box 27-3. So do familiarize yourselves with those diagnostic criteria, and note that 4 of those have to be present in order for the diagnosis to be made. When we look at treatment, many choices are available in the management and treatment of SLE. Children and their families must work closely with members of the healthcare team and take an active role in managing the disease and promoting health and well-being. The treatment plan is usually based on the child's age, sex, health, symptoms, and their lifestyle. Treatment is targeted towards preventing exacerbations, treating them when they do occur, and minimizing organ damage and complications. The initial treatment is often targeted to treat musculoskeletal symptoms such as arthritis with the NSAIDs, combined with an anti-malarial drug. If symptoms persist or worsen, steroids or methotrexate may be ordered. Additional treatment strategies are included as other body systems do develop, or body symptoms in other systems do develop. Nurses need to educate children and families about medications and to report any new symptoms or responses to the physician promptly. When we look at nursing management, you do want to note that SLE is a chronic illness. Nursing care needs to include support, recognition of treatment of infection, education about the importance of adequate fluid and electrolyte balance, nutrition, activity, and rest, as well as developmental considerations. It is necessary for the child and the family to understand the importance of complying with timelines, dosing, and effects if medications are being given. In addition, families need to know exposure to the sun can trigger a flare-up, so it should be avoided or at least limited. Teenagers need to know they are more susceptible to STDs because of the immunosuppressive medications. Pregnancy can stress the body and increase disease activity, and cytotoxic medications increase the risk for birth defects. However, if pregnancy is planned for and closely monitored, it is more likely to be successful. It is also helpful for families to know the course of the disease may become frustrating and discouraging at times because it is lifelong in nature. Remissions, exacerbations, and body image issues from medications may arise. They also need to be able to identify resources to help them through the difficult times. Participation in age-appropriate activities should be encouraged. Alright, now we will look at HIV. I'm sure you guys know what it is and about how it works. It is no different really with children. I will point out a few things for you, though, that are relevant to the pediatric population and what I want you to review. I do want you to look at and review box 27-4 in your text on pages 965, and it is carried over onto page 966. This lists the revised pediatric classification system and their clinical categories. So if you will look, it lists category A, B, C, and N. You do want to look at those. They range from not being symptomatic to being severely symptomatic. So I do want you to look at those and what it encompassed in each category. Also, I want you to take a look at the nursing alert in your text on page 969 that goes over infections prior to the diagnosis of HIV. These are a few things that you will see as a pediatric nurse, or even as a healthcare provider. You may come in contact with a pediatric patient if they are having reoccurrent otitis media, thrush, or pneumocystis carinii, or canini, however you want to say it, PCP. Those are infections that are commonly found in HIV infected infants before they are actually even diagnosed. And I know some people are wondering how this actually happens. Well, some moms don't even know that they are HIV positive, and they have passed it on to the baby, and then, the baby starts exhibiting signs and symptoms. Whereas if mom was aware, baby could be getting treated as soon as the baby is born. So that is how that usually occurs. When we look at the clinical manifestations, they can range from being completely asymptomatic with normal CD4 counts to having associated symptoms of presenting opportunistic infections or conditions that meet the criteria for an AIDS diagnosis. The severity of each clinical manifestation varies by organ system and often is the result of several factors, including viral replication in the affected tissue, an opportunistic infection of the organ, concurrent autoimmune or immunodeficiency processes in the organ, or the side effects of medication therapies for treatment of HIV or prophylaxis. You want to also review diagnosis. History is important in determining whether testing for HIV is actually even indicated, although testing should be offered to anyone who is sexually active, has drug-using sexual partners, has suspicious or documented history of sexual abuse, is pregnant, is an infant whose mother uses drugs, has used drugs, or has symptoms suggestive of HIV infection. The timing of transmission of HIV from mother to child is particularly important in the correct diagnosis of infants. The standard ELISA test can be used for anybody older than 15 to 18 months of age. It cannot be used for younger infants because of the persistence of maternal antibodies until this age. So the test would actually only be indirectly testing the mother. So really, if we tested let's say a 7-month-old infant, then if it came back positive, we're really only getting the results of the mother because the infant still has the antibodies from the mother. And so that is why they're saying they will not do the test. Well, I won't say they will not. The test is basically inconclusive for results for the infant until they reach that 15 to 18 month mark. And Just like your text says, the antibody will be positive from 3 to 6 months after the initial infection. A positive result on an ELISA is confirmed by the Western blot test, which identifies specific proteins and glycoproteins found in antibodies specific to HIV. Infants from birth to 18 months should be tested by using a viral diagnostic assay, or assay, however you want to say it. The HIV DNA polymerase chain reaction, or PCR, is the preferred test to confirm HIV infection in infants. When we look at treatment can be very complex and requires a very well coordinated multidisciplinary team approach. Depending on the stages, we want to look at the goals of management, which are to slow the progression of the disease and improve the quality of life of the infected persons. You want to just briefly look at the antiretroviral agents for HIV. Those are some of your common ones there. When looking at allergic reactions to medications, medication allergies are adverse reactions to medications or their metabolites caused by immunologic responses. Children with these allergies can have reactions after injection, or application of medication to the skin, such as your ointments, your topicals, creams, and things like that. The reactions demonstrate either systemic hypersensitivity or organ-specific patterns. When we look at clinical manifestations of these allergic reactions, they can be classified into cutaneous or multiple organ system manifestations. Cutaneous reactions are the most common, while multiple organ system involvement is more life-threatening and a more dramatic presentation. Your cutaneous reactions include urticaria or itching, angioedema, erythema, your redness, and things like that. When looking at your multi-organ system manifestations, these include anaphylaxis, nonspecific histamine release, erythema multiforme, and Stevens-Johnson syndrome, toxic epidermal necrolysis, or TEN, hypersensitivity syndromes, and medication fever. Anaphylaxis is that acute life-threatening reaction with diffuse erythema, urticaria, angioedema, pruritus, bronchospasms, laryngeal edema, hyperperistalsis, hypotension, or cardiac dysrhythmias. Anaphylaxis, sometimes known as anaphylactic shock, occurs rapidly within 5 to 30 minutes after the exposure. I do want you to look at your nursing alert in your text on page 975, which reviews medication allergies. And one more thing, I do want you to look at your family teaching box in your text on 976, which goes over anaphylaxis. And one last thing I want to talk about, or a couple of things actually, for your allergic reactions to medications. The most severe form is the Stevens-Johnson syndrome, which may exhibit widespread blisters, ulcerations, and erosions of the mucosa and involve the conjunctival lesions. A rash follows 1 to 2 days later. When we look at treatment, this varies based on the pathophysiology and the severity of the reaction. Of course, if they are allergic to a medication, we do not want to give that medication. That is an important thing to ask when we are administering medications. As far as nursing management, of course, you want to provide if an effective airway for the child if they are having a allergic reaction or an acute reaction. You want to provide comfort, especially if they are having itching or pain, and of course providing oral hygiene and skin care. When we look at family teaching, encourage caregivers and children to know the name of the offending medications and avoid exposure to being prescribed that medication in the future. Some medications may be required for life-saving treatment in the future. Drug sensitization may be needed, such as for penicillin, when there is a history of reactions to a particular class of medications. And just want to go over a few examples within this chapter before we finalize chapter 27. When you are caring for a child who is taking steroids for lupus, the nurse should monitor closely because steroid can mask signs of infection. So you do want to be careful about that. You also want to note that the child who would need further teaching, if you as the nurse were educating both the child and the parent, or even a group of children, you would know that these kids need further teaching when you're talking about lupus. If one of them states that they need to wear sunscreen in the summer to prevent rashes, we actually want them to stay out of the sun because these can prevent flare-ups. So putting on sunscreen doesn't really do them the justice. We want them to stay out of the sun as much as possible when they have lupus. Note that the following labs support the diagnosis of lupus: your thrombocytopenia, leukopenia, and a positive anti-nuclear antibody, or your ANA. You want to teach the family to report if the child starts to develop a rash after taking steroids for a long time for lupus, especially that butterfly rash that we talked about. Lastly, one last thing about juvenile arthritis and lupus. Note that steroids and non-steroidal anti-inflammatories can be used as far as treatment goes for both lupus and juvenile arthritis. And that will conclude chapter 27. Moving on. Welcome to chapter 29. Here we will talk about cellular alterations. First, we will look at cancer, which refers to a group of diseases in which there is out of control growth and spread of abnormal cells. There are two general types: solid tumors and hematological or malignancies of the blood. The name of cancer depends on its cell origin and where in the body it develops. A sarcoma is a cancer that originates in connective tissue, muscle, or bone. A carcinoma originates in epithelial tissue that consists of cells from glands, hollow organs, and outer layer of skin that lines the blood vessels. The most common childhood malignancy is leukemia, followed by tumors of the central nervous system, lymphomas, neuroblastomas, soft tissue sarcomas, Wilms tumor, and bone tumors. When we look at the anatomy and physiology, I do want you guys to review that section, but I want to point out a couple of things. Childhood cancer differs from adult cancer. Common childhood malignancies usually arise from primitive embryonic tissue or are sarcomas. Adult malignancies are of epithelial origin and are carcinomas. Children have not lived long enough for exposure to carcinogens to cause a malignancy. Routine screening, which leads to early detection, is a key to survival in many adult cancers. Screening evaluations for childhood cancer have generally not proved advantageous, and the diagnosis of cancer in children is usually made when symptoms warrant a diagnostic workup. Many children's cancers are metastatic at the time of diagnosis, whereas adult tumors are often localized. Fortunately, the prognosis in children with cancer is much better, with a 70 to 90% survival rate compared to less than 60% in the adulthood. Childhood cancer has become a curable disease, with greater than 80% of children diagnosed with cancer actually surviving. When we look at treatment modalities, the goal of cancer therapy is to rid the body of all malignant cells, thereby curing the cancer. Therapy may include surgery, chemotherapy, radiation therapy, hematopoietic stem cell transplantation, or HSCT, and biological response modifiers, or BRMs. A combination of these modalities is frequently used. I do want you to look in your text on table 29-2 on page 1025 at the cancer treatment modalities, their functions, and also their goals. The type of cancer and the extent of metastasis, known as stage, determine the appropriate treatment. Staging is used to establish a prognosis and treatment plan. Staging studies are done according to the client's diagnosis. In leukemia, a bone marrow aspirate and biopsy are done to diagnose and determine the type of leukemia. Common studies that are also done are CT bone scans, MRIs, and PET scans. An MIBG scan is specific to a neuroblastoma. Each tumor system specifies the necessary imaging studies and biology studies needed to accurately stage a specific tumor. The pediatric oncologist can then decide the client's treatment and eligibility for a clinical trial, if there is one available. When we look at surgery, the goal of surgery in cancer therapy is to remove all visible and microscopic malignant cells when possible. Surgery is used to obtain a biopsy, which is a small sample size of the tumor, which is then examined microscopically for diagnosis. Surgery also aids in tumor staging by noting the presence and existence of metastatic disease. Palliative care is given to relieve pain and improve quality of life when cancer treatment is no longer effective. When we look at chemotherapy, it is the most frequently used treatment modality in pediatric oncology and is unique because it is effective for systemic cancers that cannot be managed by surgery or radiation. Chemotherapy drugs are given in cycles to allow normal cells to actually recover. The child's disease and treatment regimen determine which drugs are used, the influence by the drug's pharmacology, side effects, classification, the child's disease, and treatment regimen. Routes of administration include IV, oral, PO, which is your oral, your intramuscular or IM, subcutaneous, and your intracatheter or intraarterial. In your text on page 1027, you'll see a list of their chemotherapeutic agents. Just review that. I won't make you know all of those because there are a lot of them. When we go through a few of the examples, I may refer back to this table in your text, which will point out a couple of the chemotherapeutic agents that may be mentioned later on. When we look at side effects of chemotherapy, the hematopoietic, gastrointestinal, hepatic, renal, integumentary, and reproductive systems are most commonly affected by the side effects of chemotherapy. When we look at the hematopoietic effects, these include myelosuppression, or a transient decrease in the blood cell production, anemia, thrombocytopenia, neutropenia, which is a decrease in the number of circulating neutrophils, and immunosuppression, which is a condition in which the patient's immune system is functioning at a lower than normal level. The lowest point in the child's blood counts or myelosuppression is called nadir and occurs approximately 10 to 14 days after the administration of most chemotherapeutic agents. If a child is anemic while undergoing chemotherapy, red blood cell transfusions may be given. Thrombocytopenia is a decrease in the number of circulating platelets. When thrombocytopenic, the child is at risk for bleeding. A platelet count of 50,000 is associated with only a slight risk of bleeding, while a platelet count of less than 20,000 poses a higher risk of spontaneous bleeding. Common sites of bleeding include the skin or mucous membranes, conjunctiva, and the nose. Intracranial visceral bleeding, although uncommon, can be life-threatening. When IM injections or venipunctures are necessary in the thrombocytopenic child, sites require application of direct pressure for up to 10 minutes to prevent bleeding. Rectal temperatures and suppositories are avoided to prevent bleeding or infection in this area. Caregivers are taught to look for signs of thrombocytopenia, which include easy bruising, petechiae, and purpura, and instructed when to notify the healthcare provider if the platelet count is very low or if there is active bleeding. A platelet transfusion may also be ordered. Children should be inspected daily for signs of bleeding. Menstruating girls who have prolonged or heavy periods may require oral contraceptives to control the vaginal bleeding. Neutrophils are cells that perform phagocytosis and destroy bacteria. When the neutrophil level is low, the child has neutropenia and is at risk for serious, life-threatening infections. To determine the severity of neutropenia, a calculation is made to determine the absolute neutrophil count, or the ANC. A child with an ANC of 500 or less is at risk for serious, life-threatening bacterial infections, which are usually caused by the normal body flora. Infection in the neutropenic child can quickly progress to septic shock and then death. Hand washing is the cornerstone of infection prevention and control in and out of hospital. When a child is neutropenic, any signs of infection must be treated emergently. The goal is to have antibiotics given within 30 minutes. The child's immune system is suppressed, which is known as immunosuppression, and is not able to respond or mount a response because of the lack of lymphocytes. Management of the immunosuppressed child includes prevention and prompt treatment of infections. Also, exposure to viral diseases such as varicella or chickenpox and measles is to be avoided if possible. I want you, if you have not already noticed, you know that the table 29-4 carries on for several pages. It starts on your 1027 in your textbooks and ends on page 1034. Like I said before, just briefly review those agents, the side effects, and how they can be given, and of course the nursing actions. When we go through some of the examples, I will refer back to this table and its contents, and you will be able to focus more in-depthly on those areas. I also want you to look at the nursing tip in your text on page 1035 about neutropenic children and how they may not show signs of infection. You can also briefly look at the calculation of the absolute neutrophil count. It will not be included on your examination, but it is good to know. You do want to check out that nursing alert in your text also on page 1035, which goes over aspirin-containing products, and NSAIDs. And now we'll look at the gastrointestinal effects. The GI effects are common. Mucotosis is called stomatitis, is an inflammation of oral mucosa that ranges from mild redness to severe painful ulcerations. The entire GI tract can be affected. Mucositis is one of the most difficult and painful side effects of cancer therapy, and usually presents several days after the administration of chemotherapy. The primary management is pain control and good oral care, which includes using a cleansing solution such as warm water or chlorhexidine to clean and rinse the oral cavity of foods, particles, debris several times a day, particularly after meal. Gently cleansing with oral sponges or ultra-soft brushes may be necessary to minimize pain as well. Other GI effects are nausea, vomiting, which may range from mild nausea to severe vomiting. Some children experience anticipatory vomiting, which occurs when the child associates a certain situation with chemotherapy and vomiting, such as riding to the hospital or entering the outpatient clinic. Prolonged nausea and vomiting and anorexia can lead to significant weight loss and weakness, which can further compromise the child's immune system. The administration of antiemetics and non-pharmacologic interventions can help to control the nausea and vomiting. When we look at the hepatic effects, liver toxicity seen in different chemotherapeutic agents ranges from The elevation of hepatic enzymes and liver fibrosis caused by long-term use of these drugs. The nurse, prior to administering the chemotherapy, must check the results and notify the healthcare provider of any abnormal findings as far as liver damage. High transaminase and bilirubin may require a dose reduction, adjustment, or postponement of chemotherapeutic agent. Looking at the renal effects, various chemotherapeutic agents, especially high-dose methotrexate and clispatin, can cause significant renal toxicity. Renal toxicity will be manifest as an increase in the BUN and serum creatinine and decrease in the urine creatinine clearance. Factors that compound renal toxicity include the use of certain antibiotics, antifungal agents, and radiation to the kidney area. Continued periodic urine examination for blood is recommended because it may occur months after the drug is given. Kidney function is also determined by the client's ability to handle body fluids. Therefore, monitoring intake and output is essential. A discrepancy in intake and output must be reported, as this may be the first indication of renal toxicity. When we look at the intake effects, alopecia or hair loss is often the side effect most associated with cancer treatment, but not all children undergoing chemotherapy will lose their hair. When it does occur, it can be devastating to both the child and the family. Hair loss from chemotherapy is not permanent usually, and regrowth often starts while the child is still receiving treatment. Children less than 5 years of age are not concerned with their hair as much as an adolescent is. All children experiencing alopecia should protect their heads from the sun and extremely cold weather. I do want you guys to look at your nursing alerts on page 1036 and 1037. The one that talks about immunosuppression and vaccines. You want to note that your kids usually will not receive some of their vaccines, especially if they're on chemotherapy. Also, the nursing alert about nothing in the rectum, especially if they are thrombocytopenic. We do not want to increase their risk for bleeding. When we look at the reproductive effects, the reproductive system is also adversely affected by chemotherapy. Most children have normal pubertal development, but fertility may still be affected. Oligomenorrhea, or your abnormally light or reduction in the menstruation, amenorrhea, excessive bleeding, or menopausal symptoms. The effect of cancer treatment on male fertility is more severe than that of female fertility. When we look at the complementary and alternative therapies, also known as CAM, this is not uncommon in pediatric oncology. CAM therapies used by children with cancer are prayer, massage, vitamins, supplements, relaxation, and imagery. The most important factor in a child's use of CAM is whether or not the child's parents use CAM. Other complementary therapies are art therapy, music therapy, and also play therapy. When we look at venous access devices, the most frequent route of delivery for anti-neoplastic drugs is IV, which is also one of the most difficult in children. For therapeutic as well as psychological reasons, most children will have a venous access device, or a VAD, which is a catheter that is usually inserted into the superior vena cava. Most of you will think of it as a PICC line. There are no restrictions on activities such as swimming for the child that Carrying on and looking at some more treatment modalities for cellular alterations, we want to look at radiation therapy. Radiation therapy is used to deliver a therapeutic dose of ionizing radiation to a tumor with minimal effects to the healthy surrounding tissues. It is the primary treatment for several pediatric malignancies such as lymphoma, solid tumors, and brain tumors. It can also be given for pain control as part of palliative care in the terminally ill clients, in which it is used to enhance the quality of remaining life. Radiation therapy is delivered by several methods, and they are listed in your text on page 1041, and they carry over to 1042. You want to know that radiation is given daily in divided doses until the total prescribed dose is delivered. At each radiation treatment, the child must remain immobile on a hard, flat surface. This may be uncomfortable for about 10 to 15 minutes it takes for preparation, positioning, and delivery of treatment. The actual treatment only lasts a few minutes. Depending upon the developmental level of the child, sedation or anesthesia may be necessary to complete these treatments. Nursing care of the child undergoing radiation therapy involves teaching about the process and its effects on the child. Children and caregivers need to know that radiation therapy is not painful, yet it may be frightening to the child and the caregiver. Pre-radiation teaching and role-playing decreases the child's anxiety and promote more cooperation. Caregivers need to know the daily time schedule and any sedation or anesthesia protocol that is used. There are some side effects to radiation as well. Radiation therapy delivered to the head and neck area will cause an ulceration of the oral mucosa. Skin in the radiated field may exhibit changes such as dryness, erythema, and pruritus. More serious reactions with skin breakdown and disquamation may warrant a delay in treatments. Good nutrition and hydration are important to maintain skin integrity, healing, and recovery. All children are to avoid sun exposure in the treatment area because radiated skin may burn more easily. The skin reaction can range from mild to erythema to severe sunburn effects. Radiation to the scalp produces alopecia that may be permanent. The child and caregiver should be made aware of this and encouraged to obtain appropriate head coverings if necessary. While whole brain radiation can cause acute, subacute, and delayed toxicity. Headache, nausea, and vomiting are common signs and symptoms of acute toxicity. Subacute toxicity is seen 5 to 7 weeks after radiation and resolves within 1 to 3 weeks. This is called somnolence syndrome. Children will experience drowsiness and may sleep up to 20 hours a day. Nausea and malaise frequently accompany this sleepiness, and fever, dysphagia, ataxia, and transient papilledema and inflammation of the optic disc may also occur. Radiation to the bones, soft tissue, and blood vessel areas of a growing child will affect growth in the treated area. Children who are most vulnerable are those less than 6 years of age or undergoing pubertal growth spurts. I do want you guys to pay attention to the family teaching on chemotherapy and radiation therapy, and it is in your text on page 1042 and 1043. Now we'll look at hematopoietic stem cell transplantation, or HSCT for short. This is also known as your bone marrow transplant. It is the replacement of the person's hematopoietic stem cells after his or her own bone marrow has been destroyed by the disease or by treatment of a malignant disease. Stem cells can be obtained from a variety of sources such as the bone marrow or umbilical cord blood. In cancer therapy, the use of hematopoietic stem cell transplantation has become increasingly accepted as treatment for leukemia, lymphomas, and certain solid tumors. For all types of HSCT, donor stem cells must be found, and this applies for all of those except for the allogenous. A suitable donor is one whose tissue type closely matches the client's genetic markers on the surface of the white blood cells called human lymphocyte antigens, or HLAs, define a person's tissue type. These HLA markers are inherited, so siblings are more likely to be compatible donors. Obtaining donors for minorities has been a challenge for bone marrow registries. Hematopoietic stem cell transplantation consists of three phases: the pre-transplant, the actual transplant, and then post-transplant. You want to read and determine the difference between those. And, of course, you want to make sure discharge planning starts when the child's condition stabilizes. With home care nursing services available now to provide parental nutrition, antibiotics, and other intravenous medications, children are able to return home sooner than they used to. Hospitalizations that used to last months or even years are now typically 6 weeks or so in duration. I also want you to look at the family teaching on going home from a stem cell transplant, and that is located in your text on page 1046. Now we'll look at the biological response modifiers, which is known as your BRM. This is also known as biotherapy or immunotherapy. It is relatively new and rapidly expanding modality of cancer treatment, and that's pretty much all I want you to know about that it's new. The ones that you need to be more familiarized with is the chemotherapy, the radiation, and of course your bone marrow transplants. As nurses who care for children receiving BRM therapy, they must be familiar, of course, with the biology of the disease being treated and the function of the side effects of the specific BRM in order to safely treat the patient. You also want to look at the family teaching box on the biological response modifiers, and that is located in your text on page 1046 as well. Now, when teaching parents about radiation therapy, as the nurse will know that they need additional teaching if they say they can use petroleum jelly if the skin becomes reddened. This is so not true. We usually do not give them petroleum jelly. We want them to actually keep the children out of the sun as much as possible. If they do happen to get a sunburn, then there are usually ointments and things that we can put on the burn so that it is not hurting as bad. Some use A&D ointment, but we do not use the regular petroleum jelly on the skin. And you also want to teach the parents that they need to actually bring the child in or call the pediatric oncologist and let them know skin has become reddened before it actually breaks down. I know your text said that the skin rarely becomes burned, but it can become burned and excoriated if you're having several radiation treatments in the same place and the skin does not have time to actually heal and regenerate. Now, when looking to undergo stem cell transplant, the nurse should be monitoring for severe diarrhea and maculopapular rash post-operatively. These are both things that the nurse has to look for. Lastly, when doing radiation therapy, the nurse should mention the following interventions, which include helping the child devise mind games to play during the procedure, administering antiemetics as prescribed, and expose the eradicated area to air. And I don't get this confused with having the child play a game, because as I stated, they have to remain still during this time. So having them do something in their mind, if they have that developmental level where they can focus, then that will be good. We do not want them moving. They have to be still. For those that do not have that developmental level, then anesthesia or sedation is used during their radiation appointments. Alright, now we're going to look at leukemia. This is a broad term describing a group of malignant diseases in which normal bone marrow elements are replaced by abnormal immature lymphocytes known as blast cells. It is the most common childhood malignancy in those under 15 years of age. In children, two forms are generally recognized. It's your ALL, or your acute lymphocytic leukemia, and the AML, which is your acute myelogenous leukemia. ALL is the most common, and looking at presenting clinical manifestations, those that you may encounter is fever, bone pain, pallor, and bruising. And most children diagnosed with ALL have been asymptomatic, or shall I say symptomatic, for only 1 to 2 weeks. Diagnosis is made with a bone marrow aspirate, and they have to find more than 25% of abnormal lymphoblasts in the bone marrow to confirm the diagnosis. The child's white blood cell count at diagnosis are most important prognostic signs in ALL. For the best prognosis, we want a WBC less than 5,000 and an age between 2 and 9. If we're looking at the worst prognosis, we have an age less than 2 years or older than 10 years and a WBC greater than 50,000. A lumbar puncture is done to assess for the presence of leukemia cells in the cerebral spinal fluid. If leukemia cells are present, central nervous system involvement is then verified. A chest x-ray is obtained to detect a mediastinal mass. Laboratory findings will show liver and or kidney involvement. Optimal treatment depends on identifying the origin of leukemia, such as B-cell precursor, mature B-cell precursor, or even the T-cell. ALL is treated with systemic chemotherapy and includes 3 phases, which include induction, consolidation, and maintenance. I do want you to review those. And unfortunately, regardless of all the success of treatment for ALL, a number of children will relapse, and those who relapse while on therapy or within 6 months of completing treatment have a poor, very poor prognosis. Stem cell transplants can be an option for those with ALL who obtain a second remission after relapse and who have a compatible donor. When we look at AML, this is the second most common type of leukemia in children, and these children usually have a poorer prognosis than those that have ALL. Of course, the etiology is unknown, and AML remains stable throughout childhood, but there tends to be a slight increase during adolescence. Children with AML present with seemingly benign symptoms resembling the flu, such as fever, fatigue, malaise, and anorexia, or they may be severe and life-threatening, such as bleeding or severe hemorrhage. Bleeding at the time of diagnosis is usually associated with thrombocytopenia, but may also be caused by disseminated intravascular coagulation, also known as DIC. In order to diagnose this, of course, a bone marrow aspirate has to be done, and more than 25% will show malignant myeloblast. For treatment, once diagnosis is made, of course, your treatment will begin promptly, attending to the presenting symptoms such as anorexia, bleeding from thrombocytopenia or DIC, infection, and metabolic abnormalities such as your hyperuricemia. Treatment for AML is with systemic chemotherapy as well. The phases of AML treatment are remission, induction, and continuation. AML is very intense and usually given as inpatient for treatment. When we look at nursing management, assessment for signs of bleeding such as change in vital signs, including a decrease in blood pressure or increase in heart rate, is of course important. We want to make sure our patients do not have thrombocytopenia or are going into DIC. Bleeding may be seen at needle puncture sites even hours after a puncture has been done. Trends in laboratory findings that suggest DIC include prolongation of the prothrombin time, a decrease in platelet count, and a decrease in fibrinogen levels. Now we'll look at brain tumors. I'll briefly go over a few of these. We won't spend too much time on them. I'll go over a couple of important key essentials that I want you to know as far as brain tumors. These are the most common solid tumors of childhood and are second only to leukemia among childhood malignancies. They are the third leading cause of death in children under 16, and prognosis varies depending upon the age of the child at diagnosis, pathology, and the location of the tumor. They are classified according to their histology and their location. Initial symptoms of the childhood brain tumor are often vague and mimic common childhood illnesses. They include irritation or irritability, vomiting, and anorexia. Increased intracranial pressure is frequently seen in the infratentorial tumors and of the posterior fossa, caused by the tumor itself or indirectly by an obstruction of the flow of cerebral spinal fluid. Symptoms include headache and vomiting, which may be worse in the morning. The vomiting may temporarily relieve the headache. Younger children may present with irritability and an increase in head circumference. Infants with increased intracranial pressure may have a raised or tense anterior fontanelle. When we look at diagnosing these brain tumors, diagnostic workup of a child with a neurological symptom includes your MRI, which has replaced the CT as the most common first diagnostic test obtained. Both tests have their advantages and disadvantages, of course. The PET scan and the thallium single photon emission computed tomography, or your SPET scan, both provide information about residual abnormalities after treatment. When we look at treating brain tumors, they're treated on an individual basis. They may include surgery, radiation therapy, or even chemotherapy, or a combination of all of them. The actual plan of treatment depends on the location and pathology of the tumor and the age of the child. Radiation or chemotherapy are often the major components of the plan. Surgery is used to remove as much of the tumor as possible while preserving normal brain function. Prognosis is improved when all or most of the tumor can be surgically resected. The goal of radiation therapy is to destroy tumor cells while sparing normal brain tissue. Because the damage of radiation causes to the developing brain, such as intellectual and growth impairment, it is avoided in children who are less than 3 years of age, if at all possible. I do want you to look at the nursing tip on your text that talks about sedation for neurodiagnostic testing. And then when we look at nursing management, a thorough neurological assessment is performed before surgery and includes vital signs, pupil size, equality and response to light, level of consciousness, and the quality of grip. Head circumference measurement and assessment of anterior fontanelle is necessary to evaluate increasing intracranial pressure. Seizure precautions is instituted both preoperatively and postoperatively. Once a tumor is identified, surgery is planned. Caregivers often do not have adequate time to comprehend all that is being asked of them. Being available, answering questions, providing written information, and providing emotional support are important nursing responsibilities. Caregivers may become overwhelmed with physical, emotion, and financial demands that the diagnosis of a brain tumor in their child brings. Nurses can be instrumental in helping them cope by introducing them to other members of the multidisciplinary team and families who have managed a similar difficult situation. It is important for nurses to help families identify other resources of support, such as extended family, friends, religious organizations, and childhood cancer support groups. Now we'll look at lymphomas. And this is a malignancy that arises from the lymphoid system. Lymphatic tissue is present throughout the body and is responsible for recognizing and destroying foreign invaders. It is responsible for developing competent lymphocytes to perform this task. Lymphomas are a malignant transformation of these cells. There are two types, known as Hodgkin's disease and non-Hodgkin's disease. Your Hodgkin's disease usually originates in the cervical lymph node. It spreads to other lymph node regions. If left untreated, it can spread to the organs. When we look at the clinical manifestations, the onset of HD is commonly not acute in nature, and the child may have had symptoms for a long time prior to seeking medical attention. The disease is usually localized at the time of diagnosis. The usual presentation is painless and large lymph nodes. The most common sites of presentation are the cervical and supraclavicular areas. Other symptoms may include malaise, anorexia, night sweats, and fever. Most children have localized disease at the time of diagnosis, but HD can metastasize to the spleen, bone marrow, and lungs. It is necessary to determine or obtain a staging evaluation to determine the extent of disease and the treatment plan. When we look at diagnosing this, it is made by a biopsy of the affected node and a histologic classification by a pathologist. Staging of the disease helps determine the prognosis and is determined by the extent of the lymph node involvement. A staging evaluation includes chest x-ray and the CT of the chest, abdomen, and the pelvis to assess for distant lymph node involvement. Stages range from 1 to 4, with 1 having the best prognosis and 4 having the worst. A gallium scan can be used to assess for metastatic disease. Bone marrow aspirates and biopsies are performed to assess for bone marrow involvement. When we look at treatment, depending on the clinical stage, at the time of diagnosis, HD treatment includes chemotherapy, radiation, or a combination of the two. Nursing management care of the child with HD includes administration of chemotherapy and management of the side effects of chemotherapy and radiation. The nurse observes the child for signs of infection and teaches the caregivers about the risk of infection. Emotional and physical support to the child and family who are experiencing cancer are always part of the holistic nursing care. Looking at non-Hodgkin's lymphoma, this is significantly different from Hodgkin's lymphoma in that there is no single focal origin, and therefore the malignant cells are rarely localized. Also, NHL has a rapid onset and presents with widespread involvement. It is more common than Hodgkin's disease in children less than 10 years of age. There are approximately 750 to 800 new cases each year in the U.S. When we look at clinical manifestations, the presenting complaint of a child with NHL is usually pain or swelling with acute onset and progression. Children with lymphoblastic NHL commonly present with mediastinal masses, pleural effusions, lymphadenopathy, and have a tendency for spread to the bone marrow and CNS. Burkitt's NHL manifests with an abdominal mass, which can mimic appendicitis and can also spread to the CNS and bone marrow. Because of the rapidity of this tumor can proliferate, most children have advanced disease at diagnosis, even though they may have had symptoms for only a short period of time. Most have stage 3 and 4 of the disease when diagnosed. Children with advanced disease may present with CNS symptoms including headaches, nausea, and vomiting. Petechiae, bruising, bleeding, and bone pain are present if the bone marrow is involved. Those with large mediastinal masses may present with respiratory distress. Of course, your diagnosis is made by biopsy. Staging evaluation includes bone marrow aspirate and biopsy, a lumbar puncture to assess for marrow and CNS involvement, respectively. Radiologic studies such as your CT of the affected area, the chest, abdomen, and pelvis, your nuclear studies such as PET scans to identify other sites of the disease, and then your laboratory evaluations, which may include your CBC, liver and kidney function tests, electrolytes, calcium, phosphorus, magnesium, and your LDH, uric acid, and a urinalysis. When we look at treatment, aggressive multi-agent chemotherapy is started as soon as possible once the diagnosis is made and staging of the tumor is actually complete. Nursing management of the child with NHL is similar to the care of the child with leukemia. There is a high incidence of tumor lysis syndrome, and these children are often admitted to the intensive care unit for initiation of treatment. Because of the intense chemotherapy these children receive, side effects are common, and nursing care involves managing these. Lastly, we'll look at neuroblastoma. This is a tumor originating from the neural crest cells, which are embryologic precursors of the sympathetic nervous system. These cells are present in the tissue found in the brain, adrenal medulla, pelvis, mediastinum, and sympathetic ganglia. A neuroblastoma may occur at any of these sites. It is the most common extracranial solid tumor that is found in children. Of course, the etiology still remains unknown. When we look at those clinical manifestations, they can present with a wide variety of symptoms depending on the location of the tumor and the extent of the disease. The most common primary site is the abdomen with involvement of the adrenal gland or the paraspinal ganglia. The tumor is most often detected by palpation of the abdominal mass that can be a firm, irregular shape and frequently crosses the midline. The child may complain of abdominal pain and fullness. Large abdominal or pelvic tumors can cause edema to the lower extremities as a result of vascular compression. Masses of the thorax can be seen on the chest x-ray, and if large enough can cause respiratory symptoms or superior vena cava syndrome. When the tumor presents in the spinal area, it can grow into the spinal foramen and cause spinal cord compression. When we look at diagnosing this, although signs and symptoms, blood and tests and imaging studies may indicate that a neuroblastoma is present, a conclusive diagnosis can be made only when neuroblastoma cells in tissue samples are seen under a microscope. When neuroblastoma is suspected, a complete history physical is done. Laboratory testing includes your CBC, liver and kidney function test, and a chemistry profile. Neuroblastoma often causes an elevation in the catecholamine metabolites, or your VMA, and your HVA, which can be measured in the urine. Bone marrow aspiration and biopsy from bilateral iliac crest sites can often confirm the diagnosis of a neuroblastoma and are necessary to determine bone marrow involvement. When we look at treatment and nursing management, the treatment plan is determined by the risk category and other prognostic markers of the disease. Treatment can include surgery, chemotherapy, radiation, biotherapy, and stem cell transplant. Surgery can be both diagnostic and therapeutic. As far as nursing management and family teaching, nursing assessment is similar to the assessment of children with other tumors such as leukemia and lymphomas. Emphasis is on the expeditious completion of metastatic workup. The initial care focuses on alleviating the child's discomfort associated with the presenting symptoms and supporting the child and family through the diagnostic workup. The nurse will need to assist with the coordination of tests and procedures and teach the family the importance of these in determining the extent of the tumor involvement. Chemotherapy or radiation therapy will begin quickly once the child is stable. Postoperatively, caregivers will need to be educated about the side effects of the treatments. Now we'll look at a couple of examples, and then we will cover the last few topics within cellular alterations. So when you're suspecting ALL, The child may exhibit a low-grade fever, painless cervical lymphadenopathy, and bleeding from the oral mucous membranes. If you are explaining bone marrow aspirations to a child with leukemia, the best explanation will include that they will feel pressure on their hip from the needle during aspiration. If the child is receiving prednisone to treat leukemia, if parents questioned, tell them that prednisone interferes with the white blood cell production. If the child is receiving chemo for ALL and the nurse suspects tumor lysis syndrome, the child would be observed as having hypocalcemia, hyperuricemia, and hyperkalemia. The child with ALL has to have a temp taken axillary rather than rectally because the child has a low platelet count. When suspecting Hodgkin's disease and palpating lymph nodes, as the nurse, you would expect to find the following lymph nodes enlarged. Usually it will be your supraclavicular and your cervical. When a child has to have surgery to remove a neuroblastoma and then they go through chemo, a good nursing diagnosis for the parents would be grieving related to advanced disease and poor prognosis. And lastly, when you are suspecting a neuroblastoma, as the nurse, you would suspect that they will probably do a 24-hour urine specimen to test for catecholamines. Alright, we're going to finish up by looking at just a few more cellular alterations, one of those being Wilms tumor, which is also known as your nephroblastoma. This is the tumor that arises in the kidneys. When we look at clinical manifestations of this, an abdominal mass is the most common presentation of Wilms tumor. A large flank mass is usually found in the healthy child by a family member. The mass presents on one side and seldom crosses the midline, as does the neuroblastoma. Some children experience pain, microscopic or gross hematuria, hypertension, and general malaise. When we're diagnosing this, an abdominal ultrasound is often the first test ordered and can detect a solid intrarenal mass. Rapidly growing tumors migrate toward the point of least resistance, and it is not unusual to find Wilms tumor infiltrating the renal veins or inferior vena cava. Ultrasound will also evaluate the unaffected kidney and abdominal lymph nodes for any signs of disease. An abdominal CT or MRI will give a clearer preoperative view of the abdomen. When we look at treatment, the usual treatment for this is surgical resection of the affected kidney, which is called a nephrectomy, followed by chemotherapy and at times radiation. The treatment used depends upon the extent of the disease and histology of the mass. Preoperatively, it is important to monitor the child's blood pressure. Hypertensive children are at risk for hypotension during the nephrectomy when the renal vessels are tied off. Wilms tumor is highly radiosensitive, and in the past, all children receive radiation. Today, radiation therapy is used only in those who have metastatic disease, residual tumor after the surgical resection, or recurrent tumors. The prognosis for children with Wilms tumor continues to improve. When we're looking at nursing management, caregivers have little time to prepare for major surgery involved with the nephrectomy and diagnosis of cancer. The nurse should remain available to answer any questions and comments and concerns. Chemotherapy is started soon after surgery, usually before the child is discharged post-operatively. Pain control is necessary after the nephrectomy and given around the clock for the first 24 hours. By discharge, most children are no longer receiving pain medication. And when you're educating the parents about Wilms tumor, especially if they are going to have chemotherapy afterwards, make sure that the parents know that the child has to take antibiotics twice a day. Usually it will range from 7 to 14 days, but they do have to take them twice a day. Okay, now let's look at bone tumors, and this will close out our cellular alteration chapter. Malignant bone tumors account for approximately 5% of all childhood cancers. The two most common bone tumors are osteogenic sarcoma and Ewing sarcoma. Osteogenic, also called osteosarcoma, is a tumor of the bone that usually occurs in growth metaphysis or the end of long bones. Trauma is frequently associated with the diagnosis of osteosarcoma. Rather than being the cause of the tumor, trauma is the event that brings the malignancy to the attention of the child, the family, and the healthcare provider. When we look at clinical manifestations, pain at the site of the tumor is almost always present and frequently is associated with swelling or a palpable mass. When we look at diagnosing the child with a suspected tumor of the bone, requires complete evaluation, including history, physical exam, x-rays on the primary site, and chest. Often characteristic patterns seen on chest x-ray suggest histology of a bone tumor, but more complete evaluation and biopsy are needed. Osteosarcomas are usually treated with surgical resection of the affected bone, and multi-agent chemotherapy is used to eradicate any microscopic disease that could lead to metastasis. Amputation was the surgical treatment of choice that was used in the past, but now many children can be offered a limb-sparing procedure. Limb-sparing surgery uses cadaver bones or an endoprosthetic device, such as a total hip joint or knee, to replace the section of the bone with the tumor that was excised. Both amputation and limb-sparing surgery seek to excise the tumor completely and preserve the adjacent nerves and vessels. Aggressive chemotherapy is restarted after a few weeks of post-operative recovery. Osteosarcoma is radiation resistant, and this modality is rarely used in primary treatment. Occasionally, radiation is used for pain palliation in clients whose disease is unresponsive to the chemotherapy. When we look at nursing management, pain from the bone lesions of osteosarcoma in most cases requires analgesics prior to surgery. Post-operative pain medication needs to be given around the clock. Clients who are under amputation may experience phantom limb pain. And after limb-sparing surgery, the client is at risk for altered tissue perfusion and nerve damage in the affected limb. When we look at Ewing sarcoma, this is a highly malignant bone tumor with a histologic appearance and presentation that are different from osteosarcoma. With osteosarcoma, pain and swelling at the site of the tumor are usual presenting symptoms, whereas with Ewing sarcoma, this is also true. Pain may be caused by a tumor under the periosteum or the tissue covering the bone, or by a fracture of the weakened bone. Unlike osteosarcoma, children with Ewing sarcoma may present with systemic signs and symptoms, including weight loss, fever, and an increased sedimentation rate. Diagnosis is usually made by a biopsy of the bone lesion, and then treatment is usually surgical resection when possible. And radiation therapy is used for Ewing sarcoma. If the bone is expendable, such as a rib or fibula, then the entire bone is removed. Looking at soft tissue sarcoma, this is a malignant tumor that arises in the mesenchymal cells. As with other solid tumors, the presentation of soft tissue sarcomas depends upon the location, with the most common symptom being a hard, non-tender mass. Tumors in the extremities are similar to traumatic hematomas, which are raised and easily palpable. The tumor is fixed to underlying muscle and can involve the skin. When rhabdomyosarcoma arises in the retroperitoneal area, it is usually asymptomatic until the disease is widespread and the mass is usually very large. The diagnosis of rhabdomyosarcoma and soft tissue sarcoma is confirmed after tumor biopsy or actually a resection. Radiologic studies include CT and MRI. PET scans can also be done. Blood testing such as your CBC, urinalysis, blood chemistry, and liver function studies can also be performed. When we look at treatment, the primary treatment for rhabdomyosarcoma and soft tissue sarcoma is wide surgical resection whenever feasible. Only about 1 in 6 tumors can be completely removed because of the location or metastatic dissemination. Radiation therapy is used to control tumor growth by eradication of gross microscopic disease. Chemotherapy is recommended in all children with rhabdomyosarcoma and soft tissue sarcoma. The use of chemotherapy has increased the survival rate in these children, whether they have metastatic disease at diagnosis or not. When we look at family teaching, nursing management of the child with rhabdomyosarcoma emphasizes emotional support and education of the client. Therapy is multimodal and intense in nature. As with other malignancies, teaching about prevention and early recognition of signs, side effects of treatments, or reoccurrences cannot be overemphasized. Lastly, we'll look at retinoblastoma. This is a rare form of cancer in children and exceptionally uncommon in adults. It is a tumor of the eye that develops when immature retinal cells called retinoblasts become malignant and grow out of control. Clinical manifestations, this is detected by the caregiver who notices a whitish glow in the pupil. They'll usually have what we call a cat eye reflex instead of the typical red eye reflex that appears in photographs. This is a common manifestation. Other signs include strabismus and red painful eyes, and eventually blindness, which is a late manifestation. Diagnosis is made by an ophthalmologist, and they are able to do a thorough eye examination under anesthesia. Ultrasound, CT, or MRI are most often ordered imaging studies when verifying this tumor. Bone marrow aspirate and lumbar puncture also provide information about metastatic disease spread for staging prior to treatment. Of course, treatment depends on whether the tumor is unilateral or bilateral, quality of vision, and whether the tumor extends beyond the globe. Surgery, radiation therapy, laser therapy, cryotherapy, and chemotherapy are all used to treat this type of tumor. When the tumor is found in only one eye and vision has been destroyed, the usual treatment is enucleation or surgical removal of the eye. If bilateral disease is present and there is still some useful vision, then other forms of treatment are usually used. When we look at the nursing management, it is important for the child. Family teaching for retinoblastoma includes several therapeutic approaches, including ophthalmic surgery, chemotherapy, and radiation therapy. The multidisciplinary approach also includes genetic counseling and services for the visually impaired. I do want you guys to review the late effects of chemotherapy in your text, as well as some of the challenges of the pediatric oncology nurse. And with that being said, that will conclude chapter 29 on cellular alterations.